Yeah? All right. I'd like to welcome you to the ER-positive breast cancer, metastatic breast cancer breakout. What I'd like you to do is kind of sit here and imagine. Imagine that you're on a tightrope high up in the air. It's a really, really dismal day. You don't know whether the tightrope is going to continue on or whether it's going to break and you'll fall to your death. You don't see a lot of activity around you. You feel quite alone. And then you look down and you see that someone's holding a pink party. They're having fun. There's glitter. There's all kinds of stuff happening down there. But you're not part of that party. You're at a whole different plane. You're way up there. And all you want to do is yell down to those people, look up. Look up. Those of us with metastatic breast cancer feel like we're on that tightrope. And the nice thing about coming here to Living Beyond Breast Cancer is that you meet other people who are on that tightrope. It may not be the same tightrope. It might be going in a different direction, but we're all trying to figure it out. We're all trying to take one positive step after another, and coming here is so huge. I've been a helpline volunteer for Living Beyond Breast Cancer for a number of years. And so those who call in and want to talk to someone who has metastatic breast cancer as well can call in and get a peer match, and I would be one of the peer match people. And sometimes all I do is listen, and that's fine, because sometimes people just need to talk to someone who can understand, and that is a big deal. So make sure that when you're here, you listen to people, you understand those people, you also can tell your story, because your story is powerful. I've heard well over 200 stories in my time as a helpline volunteer for 3 different groups, and each one of them is remarkable. I've been living with metastatic breast cancer since 1998. And no, I don't consider that I have chronic disease. I have been on 23 different treatments, some of them repeated, and I have always been on treatment, and I've always had positive scans. I've never had one that showed completely clear. So it is possible to live on. Some days I feel like I'm not living, and I have had times when I've had to call a mental health hotline in order to get help, because I thought my mind was dying, and I felt like I was just useless, and it was horrible. It was a horrible feeling. So when you come here to places like this, you can see what other people are doing. You can reach out and get help, and going to the booths and learning about what services are available are huge. But this session is not about me. It's about you, and it's about Dr. Vasan. Okay, it's Vasan. Okay, not Vasan, not Vasan. Well, maybe, if you're from Wisconsin, it's Vasan. I don't know. What about that? Probably is. All right, we are being live streamed, so hello, you guys out in Webland. Thank you for joining in. Yay! You get to hear what's going on. That's awesome. So Dr. Vasan will be speaking for the next 45 minutes. And then you'll have time for questions. And we'll be taking your questions by text like we did in the earlier session. And that number, I think you already have, is 610-365-7532. Okay, for the next 20 minutes. 610-365. I feel like I'm doing an infomercial. 7532. All right. That's not on the screen? Okay, it'll be on the screen a little bit later. And ask your neighbors, because some of them will already have it. Okay. Anyway, in introducing Dr. Vasan, he is an assistant attending physician in the breast medicine services at Memorial Sloan Kettering Cancer Center. But he was raised in West Virginia. All right? So he went from being a small town boy to a big town doctor. And he is a singer. He sings in a semi-professional choir at least 3 hours a week, and it's with the Trinity Wall Street group. And if you look at them on the internet, they're really great. Trinity Wall Street group. They have some really, really great pieces, and he sings well. Anyway, I would like to introduce and to welcome Dr. Vasan.
Thank you, Sandy. That was a very generous introduction. Thank you all for having me, and thank you to the organizers of LBBC. So today I will be giving you a medical update on hormone receptor-positive or estrogen receptor-positive, ER-positive metastatic breast cancer. And a lot of the talk will be, of course, about some historical studies, but a lot of these historical studies really are important in order to understand the future studies. We all stand on the shoulders of giants. I'm a physician scientist. I consider Angie DiMichele one of those giants. She led one of the first clinical trials of palbociclib or Ibrance, and so it's really important to understand those trials because it gives us context for the future and all of the amazing advances. These are my disclosures. So I will outline the natural history of ER-positive breast cancer and the historical paradigms of therapy. I'll go over guidelines. As we'll see, the guidelines are actually quite vague, and the standard of care therapies and how we sort of fit them into a patient's disease. I'll talk about new therapies and clinical trials, some of which we expect/hope will be FDA approved very soon, others of which are just look extremely promising and drugs that I'm very excited about as a clinician. And we'll talk a little bit about managing side effects. We'll sprinkle that in as we talk about the therapies. So, I've received a lot of advice over my time as a doctor, and I really like to pass on this advice to other doctors in training, but I actually think all of this is very relevant for patients with metastatic breast cancer. For me as a clinician, one of the most important things is to know and understand why a patient is on a particular therapy at a particular point in time. ER-positive metastatic breast cancer is a huge catch-all, but there are reasons why one therapy is preferred over another, and it could have to do with the molecular features or the amount of disease or the side effects that a patient is having. And so as a patient, knowing that information can really be a tremendous power. I think point number 2, Angie touched on this in her talk, is it is very important to understand prognostic reality. We all know that women die from metastatic breast cancer. And I think to sugarcoat that actually undermines the message, and that's not really what it's about. It's about communicating this reality, but also balancing that with the fact that every year we have so many new therapies that get approved, totally new drugs or old drugs that are used in a new way, that are used in a patient population where we see, aha, this is a better use of the drug. And so I think balancing those two aspects is really what I want to communicate to all my patients. Guidelines are helpful. They are not the gospel. Sandy's been living with metastatic ER-positive breast cancer for 20 years, and it takes creativity. It takes a huge understanding of all the treatments available, toggling back and forth between different drugs and clinical trials, and so there's a science and there's an art. Don't take a therapy that's worse than the disease. Our goal as oncologists is to improve and extend survival while maintaining the highest quality of life possible. If you have a side effect that's usual or unusual, please let your doctors know. And there are actually a lot of creative interventions that people have done to manage these side effects. And then finally, I think this speaks to the motto of this year's conference of Thriving Together. Live your best life and strive to manage burnout. This is true for us as doctors, it's true for patients, and recognizing as well that cancer affects a patient, but it also affects your family and your loved ones. So just a show of hands, I'd like to know maybe how many people in the audience, their initial diagnosis of breast cancer was actually metastatic disease. We call that de novo metastatic disease. Okay, a very large number of people. And then, of course, that is a group of patients we see, but more commonly what we see is that patients develop metastatic disease after having surgery X number of years ago for a localized breast cancer. And so how many people in the audience develop metastatic disease, let's say 0 to 5 years after surgery? Okay, there's a group. So what about 5 to 10 years? Okay, there's a group, smaller. And then what about 10 to 20 years? Okay, see, so this is just a perfect example of what we call the natural history of ER-positive breast cancer. There's this huge variation, and so these are the types of patients like you all that we're trying to get a handle on. Is there something about a patient who develops metastatic disease after 20 years that's different from 5 years, and those sorts of questions? And I think that this point really is illustrated by a recent analysis of patients that was published very recently in the New England Journal. And what this study was, it was a retrospective study, so they're looking backwards in time, of over 60,000 women with ER-positive breast cancer, localized breast cancer, after stopping endocrine therapy. As we all know, endocrine therapy is usually given for 5 years, so these curves start at 5 years. And what was really surprising about this study, though it really agreed with all of the anecdotal evidence that we had, is that even in patients with small localized breast cancers, less than 2 centimeters, lymph node negative, really the smallest type of tumor that you can have, there is a real number probability of developing metastatic disease. So the yellow curve is no lymph nodes, and it goes up to the red curve with multiple lymph nodes. And I think there are caveats to this report. Certainly, it's an overestimate of risk, right? These patients were from the 70s to recently. We've had tremendous advances in surgery and radiation and chemo and endocrine therapy and targeted therapies. But I think it really gets to the semantics issue, and Sandy also pointed this out. You know, a patient with localized breast cancer still has, after receiving the state-of-the-art therapies, a non-zero probability, a real number probability of developing metastatic disease. And I think this is really the battle cry for oncologists and for researchers, because the question is really, how do we bend this curve? How do we identify disease earlier? How do we get better responses to therapy? How do we increase survival for patients with metastatic breast cancer? And the points are really to try to deepen responses to therapy, to understand drug resistance. Cancer cells will eventually always outsmart a therapy, to manage side effects so that patients can stay on therapies longer, and then also to be able to detect cancer earlier. And we'll really hit on some of these points. So how do we treat ER-positive metastatic breast cancer? So these are the therapies that we use, of course, in the localized disease setting as well as in the metastatic disease setting. And when I explain to patients, I actually like to use this metaphor of lock and key, because while it's a simplistic metaphor, it actually, I think, can allow for a lot of description in terms of how all of these molecules work. And these molecules, tamoxifen, aromatase inhibitors, fulvestrant, these are developed over 20 to 30 years, really unbelievable science that has led to these discoveries. And so, of course, the goal of therapy in ER-positive metastatic breast cancer is to decrease estrogen synthesis and/or activity. And so the way that I think about it is that you have precursor molecules, which I've illustrated as sort of metal, that can make estrogen, which is like a key. And estrogen binds to the estrogen receptor, which I think of as a lock on a door. And that binding can potentiate or cause ER-positive breast cancer. Now, there are a lot of ways that this pathway can get hijacked. There are ways that the lock can sort of come undone. There are ways that the amount of estrogen might be very high. But I think this is a nice metaphor, because when we start to think about all the therapies in estrogen receptor-positive breast cancer, I think we can sort of figure out where all of the ways to block the pathway are. So the first is ovarian suppression, or LHRH agonists. So on the third column is the agent. So many women who are premenopausal will either be on an ovarian suppression injection like Lupron or Luprolide, or have surgical removal of the ovaries, an oophorectomy. And the way that I think about how that works is that ovaries, of course, make estrogen, and they make some of the precursor molecules. So it sort of decreases the it decreases the amount of metal, decreases the number of keys. Aromatase inhibitors, of course, this is a standard therapy, letrozole, anastrozole, exemestane, and these are used in women who are postmenopausal. And aromatase is an enzyme that converts some of these upstream molecules, precursor molecules, into estrogen, but it does it outside of the ovaries. It's in fat cells and the liver, and so it's really an X over that arrow. It disrupts the conversion of the metal to the key. The third class of medications is tamoxifen, which is a selective estrogen receptor modulator. And tamoxifen directly binds to ER, but it downregulates its activity. And so I think of that as the key can't get into the lock. And then finally, fulvestrant, which is a estrogen receptor degrader. It binds to ER and inhibits it, but it also degrades the lock. And so I've sort of shown that here in like a lighter color. But the idea that if you degrade the lock on the door still remains locked, and so it won't increase the breast cancer. And so again, these are metaphors, of course, or these are comparisons, but I think that it can illustrate really the number of mechanisms that we think about in how to target ER-positive disease. And I think it's really important to note that endocrine therapies can control ER-positive metastatic breast cancer for very long periods of time, months to years. That's in contrast to chemotherapy, where there are a large number of chemo agents available, and many patients with ER-positive metastatic breast cancer will be on these therapies. But we know that in general, these are old studies, of course, but we know that in general, chemotherapy response rates decrease with every agent, subsequent with every agent, and that time to progression decreases as well. And so while of course there are exceptions, generally chemotherapy controls ER-positive metastatic breast cancer for shorter periods of time. I would say months, perhaps years in a best case scenario. And so this is an example of these guidelines that I mentioned before, which are actually quite vague. This is adapted from the NCCN. And as you can see on the left-hand side in the black columns, these are the hormone-based therapies or combination-based therapies that we think about initially. And then when the cancer becomes resistant to those, and of course that can sometimes be months, but it could also be decades, right, as we've just seen, eventually we will start to think about chemotherapy and really think about that blue column and agents in that column. However, as you can see, this is very, very vague, and I actually put the clinical trials piece in the middle because as an oncologist, because we know that chemotherapy, you get these shorter and shorter durations of response, I often, when is the right time to consider a clinical trial? And one response to that would be after many of these hormonal agents have perhaps stopped working, but before starting chemotherapy. There's a window often where patients may have very little symptoms or no symptoms at all, and that considering a creative clinical trial option may be a good strategy for them. So one important question is there an optimal sequence or best approach in ER-positive metastatic breast cancer? And I'll try to make the case that I think there is. So just a couple slides that I won't spend a lot of time on just in terms of historical therapies. We know that in metastatic breast cancer, for premenopausal women who have functioning ovaries that can make estrogen and potentiate the breast cancer, we know that ovarian suppression improves survival. This is an old study looking at tamoxifen with one of these shots, similar to Lupron, and survival is better. And the reason for that is that it decreases the sort of effective amount of estrogen. The second historical piece of data that you all know, of course, is that aromatase inhibitors improve the time to progression in postmenopausal women with metastatic breast cancer compared to tamoxifen. And so in red are the amount of time that a woman is on letrozole versus tamoxifen, and the overall survival in many of these studies is actually the same. But in general, aromatase inhibitors are the preferred agent for postmenopausal women. Now, how do we build on that? And so this is a trial that actually reported several years ago, and actually the final report just came out about a week ago in the New England Journal, which, as you know, is one of our highest medical journals. And this was a trial that actually looked at combining an aromatase inhibitor with fulvestrant. So combining the drug that inhibits the making of the keys with the degrader of the lock, if you will. And what they found is that combining these two therapies actually improves overall survival. That just got announced quite recently. And when they looked at who are those patients, it turns out that the patients with de novo metastatic disease, patients who had never been on an endocrine therapy, whose cancers had never seen an endocrine therapy, those were actually the group of patients maybe that benefited even more. And I think this is a very interesting study. I wrote in the bottom that there was actually what we call crossover, meaning that patients who didn't get the combination, if they progressed, they would get the combination. And still with that, there was still an overall survival benefit. I think this is a really amazing study because it shows that combining drugs that have been around for a while in a different way can actually improve survival. And I think it'll be very interesting to see how this may change the landscape of first-line therapy in patients. So the other study that was very interesting, again, noting that fulvestrant in that first-line setting is very effective, is the question, again, in these patients with de novo disease, how does fulvestrant compare with anastrozole? And so this is a trial called the Falcon trial that was also recently published. Again, first-line setting, single agent, where fulvestrant led to an improved progression-free survival compared to anastrozole. It's a small difference. It's 3 months, but it is significant. And I think that the trial I just presented plus this trial, it's hard to interpret how these will change the standard of care given that CDK4/6 inhibitors have really totally altered the landscape. But I think that it will be interesting to see clinical trials in the future that are using fulvestrant as the endocrine agent in that first-line setting, especially for patients with de novo disease where we think the biology is different. So those are some of the more historical trials. And now I want to talk about newer therapies that are FDA approved or drugs that are really exciting drugs in the pipeline. And a lot of these therapies are trying to address mechanisms of endocrine therapy resistance. So I do want to talk a little bit about the science here, because I think it really does change the way, it certainly changes the way I look at all of these molecules. The estrogen receptor is a protein that causes something called transcription. And if you all remember back from high school, DNA makes RNA, makes proteins. And so DNA to RNA, that's the process that's called transcription. Okay, and that's important because it drives a lot of different genes to start making RNA and start having real functions in the cell, including causing cancer. Now, estrogen is regulated. It's very, very tightly regulated by a whole host of factors. And some of those factors are shown here. And one of those factors is the CDK4/6 pathway, which I'll show a little bit more in the next slide. The second pathway is what we call signaling pathways. And the way that I think about signaling is sort of like a house with a lot of different light switches, and some light switches are on and off, some are off, but turning one on can maybe change another being on or off. And it's this very complicated network of lots of different proteins. And in ER-positive breast cancer, perhaps one of the most important signaling pathways is the PI3 kinase AKT-mTOR pathway, and we'll talk a little bit more about that. And then finally, in very recent work, deregulation of the estrogen receptor, sort of hijacking the estrogen receptor by mutations in the estrogen receptor, can actually cause resistance to aromatase inhibitors, and those are mutations in the estrogen receptor. So the CDK4/6 pathway, so we're all familiar with these amazing therapies that have just totally changed the way that we treat patients. There are now 3 FDA-approved drugs that are shown on the right: palbociclib, ribociclib, abemaciclib. And what exactly are these molecules doing? So again, we'll remember back to high school science class, we all learned about mitosis and how cells divide. And mitosis is part of what we call the cell cycle. So all cells cycle through these processes. They grow, they make DNA, they grow again, and then they divide. And that whole process is really tightly controlled by brake mechanisms, right? It makes sense. If that were just if that could go awry, then a lot of bad things can happen. So there's a lot of mechanisms that control the cell cycle. And one of those mechanisms is the CDK4/6 pathway. It turns on a protein called RB, which releases the brakes on another protein called E2F, and that causes progression through the cell cycle normally. So then inhibiting CDK4/6 prevents the progression through the cell cycle and decreases cell growth. And that has been known for a long time, for decades. A lot of this was Nobel Prize-winning work. But what was the more recent breakthrough was the finding initially by Dennis Slayman's group at UCLA, that in combination with endocrine therapy, inhibiting CDK4/6 can kill more ER-positive breast cancer cells. And so that was the preclinical rationale to start testing this drug. And I mentioned, of course, Angie G. Michel was one of the real leaders in this field, is one of the real leaders in this field. We now have 3 FDA-approved CDK4/6 inhibitors. This makes, I think, my job easier as an oncologist, because in the past couple of years, one drug would be approved in one setting, but one was not approved, or the trial had come out. The bottom line is that now all 3 drugs are approved with AI and with fulvestrant. And that's in this third third row here, FDA approval status. Generally, when we give these drugs, and I'll go into this a little later, we give them with an aromatase inhibitor in the first-line setting or with fulvestrant in the second-line setting, but there are roles for fulvestrant in the first-line setting. A couple salient clinical points when I talk to patients about these drugs. So I think of palbociclib and ribociclib as being more similar to each other. They're both dosed daily, 3 weeks on, 1 week off. And that 1 week off is required because these inhibitors can inhibit the bone marrow and inhibit the making of white blood cells. So you need that 1 week off for your white blood cells to improve, for your immunity to improve, not unlike chemotherapy. On the other hand, abemaciclib is dosed continuously. And we think that the reason for that is, this is getting a little into the weeds, but again, I think it's important. We think the reason for that is that CDK4 is really what's driving the breast cancer. CDK6, it turns out, is actually really important in the bone marrow, and abemaciclib hits CDK6 less. And so we think that maybe that's the reason why it can be dosed continuously. You take it every day, and the side effect profile is different. The clinical trials that have passed phase 3s are listed, and we talked about the FDA approval status. In terms of side effects, so again, palbociclib and ribociclib I think of as more similar. Decreased white blood cells, decreased platelets. Patients on this, of course, are getting their blood counts checked regularly. Abemaciclib, on the other hand, the neutropenia, the decreased white blood cells, is less, but diarrhea and fatigue are more common symptoms. I heard some laughs, so people know this. And the monitoring is also different, a little different for palbo, and for all three, you need blood counts. For ribociclib and abemaciclib, liver function tests, maybe some checking of the heart. So the bottom line here is that in the first-line setting, all of these drugs improve progression-free survival by about 10 months. And I actually think it's amazing for the field that we have we have so many trials that really agree with each other, that are harmonizing with each other. It really points to the power of these drugs as a class in treating this disease. Very recently, in the past couple months, the overall survival data reported from PALOMA-3, which was palbociclib plus fulvestrant, numerically higher, 35 months versus 28 months, not statistically significant. There was some crossover, and perhaps that's the reason why. It doesn't really change the way we think about these drugs, but it is a new piece of data. Oh, sorry, I should say it doesn't change the way we think about these drugs in the sense that we will still obviously prescribe these drugs, but I think that we will learn more about the overall survival as all these trials report. Perhaps the most vexing question, I think, in the translational research breast cancer field is who responds to CDK4/6 inhibitors and who doesn't. There has been a tremendous amount of work investigating this from cell lines to mouse models to patient samples to analyzing all the clinical trials. And unfortunately, what we're still left with even today is that aside from just ER positivity, there's really no biomarker that predicts clinical response, excuse me, this should say CDK4/6, clinical response to CDK4/6 inhibitors. Now, this is an example of one of these studies that was done based on the ribociclib trial, where they looked at a bunch of different genes and different levels of expression. And the goal here was maybe there's a group, these horizontal bars, maybe there's a group that favors placebo plus letrozole, meaning a group that doesn't benefit from ribociclib. But it turns out actually all of these groups benefit from ribociclib. And I think that we still need better ways of understanding who benefits. It's possible that some sort of a multi-gene approach, not dissimilar to something like Oncotype, may help us figure that out. But this is still a big black box, and I think one of the most important questions in the field. So combining a lot of what I told you about before, this is how I think about a framework for first-line therapies in ER-positive metastatic breast cancer. So taking these 4 red boxes, if you will, the first box being single-agent therapies. And of course, before CDK4/6 inhibitors, this is how we treated patients with an aromatase inhibitor or fulvestrant. One of the clinical parameters that we think about a lot as oncologists is what's called the disease-free interval, which is the amount of time after completing adjuvant endocrine therapy. So if a patient progresses within the first 5 years of getting an AI or tamoxifen, that's a very low number, zero. But if a patient has finished tamoxifen, finished an aromatase inhibitor, and let's say 10 years later develops metastatic disease, that disease-free interval is 10 years, okay? So that is one way that we think about differentiating between these therapies. With the single agents based on the Falcon data, we have some data that for de novo metastatic patients that fulvestrant is better than anastrozole as a single agent. So then moving over to the right-hand column, the combination first-line therapies, again, now that CDK4/6 inhibitors have totally altered the landscape in amazing ways, we combine them with an AI and fulvestrant, very similarly thinking about this disease-free interval. And we also have data based on that SWOG trial I just showed you that perhaps fulvestrant and anastrozole together may be more effective in patients with de novo metastatic disease. So this is just a framework. This is how I think about, one way to think about therapies for patients, but it really shows the tremendous progress that is made in this disease in actually a very short amount of time. So I want to now talk about drugs that are approved and in late-stage trials that target the PI3 kinase mTOR signaling pathway. So this is actually, I'm a physician scientist. I work in the lab of Lou Cantley, who actually discovered PI3 kinase about 20 years ago. And this is such an important signaling pathway in breast cancer. It's highly upregulated in ER-positive breast cancer. PIK3CA, and this is where the naming and the genes gets a little confusing, but PIK3CA is a gene and it codes for a subunit of the PI3 kinase complex. And PIK3CA is mutated in about 40% of ER-positive breast cancer, so this is a big number. But unfortunately, historically, it's been a very difficult pathway to drug. And there's several reasons for this. One of them is that there are multiple, what we call isoforms, versions, if you will, multiple versions of PI3 kinase in different cells in the body. So some of these PI3 kinase proteins are in immune cells versus cancer cells. And so, and it turns out that there's actually drugs that target one version of PI3 kinase that are actually FDA approved in leukemia and lymphoma. Another reason why this pathway is very difficult to drug is that the PI3 kinase pathway is very intimately involved in insulin signaling. And so a lot of patients who are on these drugs can get diabetic-like side effects, high blood sugars, rash, symptoms like that, and, or new onset diabetes. Initial efforts in this field really focused on mTOR inhibition. I've shown mTOR as the protein in the red circle, which is downstream. I think this is a really beautiful example of almost like an Indiana Jones chemistry approach, if you will, because this drug, everolimus, the original name was rapamycin, was actually discovered on Easter Island, and the indigenous name of Easter Island is Rapa Nui, so that's where the Rapa comes from. So this drug was actually discovered and then synthesized and then found to be very effective for breast cancer. And so there have been multiple trials that have looked at combining everolimus with endocrine therapy. The first trial, which you all in the room are familiar with, is the Bolero-2 trial, combining everolimus with exemestane. This was a positive trial. This is all for progression-free survival. But what's, I think, just as interesting is the fact that people have also studied everolimus with the other agents, with fulvestrant and with tamoxifen. And in all cases, combining everolimus with an endocrine agent improves the efficacy of the endocrine agent. These are all as second-line therapies. And so I think this is really a great addition to the field that we have this data, again, that harmonize across multiple trials that adding this drug that targets the PI3 kinase pathway improves progression-free survival. Again, just like with CDK4/6 inhibitors, aside from ER positivity, unfortunately, we don't have any biomarkers that predict clinical response to everolimus. And that's important because these drugs have a lot of side effects. They have mouth sores, which we call stomatitis. I talked about the high blood sugar and diabetes. Patients can get lung inflammation called pneumonitis, and also fatigue. And so how do we start to manage some of these side effects? This was a really, really wonderful study that Hope Rugo at UCSF in San Francisco ran called the SWISH study. We know that patients on everolimus can get a lot of mouth sores. And one thought was that, well, maybe something like a steroid mouth rinse could somehow change that. And this study was just a beautiful study that showed that a steroid mouth rinse decreases the mouth sores for everolimus. In the panel A, this is from, or sorry, excuse me, panel B is the Bolero-2 trial, where 2/3 of patients had some amount of mouth sores. And in panel A, only 20% of patients had mouth sores. And so this is a really data-driven scientific way in terms of managing a side effect. And I think this is so important because this is how patients stay on therapies for longer amounts of time. So going back to the PI, so all of the drugs that I've told you about thus far are FDA approved. So now I'm going to move into sort of the drugs that are in late-stage clinical trials that we anticipate will be approved soon. So again, going back to the PI3 kinase pathway, PIK3CA, that gene is mutated in 40% of ER-positive breast cancer. And there's ample data that this mutation is what we call a driver mutation. By itself, it can drive breast cancer, and that inhibiting it will kill breast cancer cells. And so this has spurred a large interest in developing inhibitors specifically against the PI3 kinase complex. And one of those inhibitors is a drug called alpelisib, and it inhibits specifically the alpha isoform, the alpha version of this protein complex. And so this trial just reported a couple months ago at ESMO, the European Oncology meeting. This trial investigated adding alpelisib to fulvestrant versus fulvestrant alone in patients who had progressed on prior endocrine therapies. And this was a positive study. The progression-free survival went from 5.7 months to 11 months. And we in the field hope that this will become a new standard of care in ER-positive PIK3CA mutant breast cancer, which represents about 40% of this disease. Now, like everolimus, these drugs are also challenging to give, and I think a big push is going to be trying to understand these side effects better and figure out ways to manage them. I do want to say, taking one step back, all new therapies at one point in time are very challenging to give in oncology. All cancer therapies, right? Chemotherapy, when it was first invented, things like nausea and vomiting were tremendous side effects that now we have amazing ways to manage. But back in the 80s, we didn't. And I think that all of these therapies are like that. They go through these cycles where we have to understand the side effects better so that patients can stay on these drugs longer and figure out ways to manage them. And so one very interesting intervention that's been proposed to combat this resistance, because you're inhibiting insulin signaling, is to think about changes in diet. And there's a new type of, or it's not a new type of diet, a diet called the ketogenic diet. And Lee Jones, I know, is going to be here tomorrow, and he may discuss more about this. But there's data in mouse models that actually giving mice ketogenic diets can actually greatly enhance the efficacy of these PI3 kinase inhibitors. And so maybe that's a way in patients that diet and drugs can sort of work together to help patients at the end of the day. So I want to get through the other slides. These are all going to be on sort of newer therapies. So of course the big question in the field is, why do patients become resistant to AIs or other endocrine therapies? On the left, this is a study that we've been involved in, looking at sequencing with genetic approaches, sequencing tumors, metastatic ER-positive breast cancer tumors. And there's a large number of what we call resistance mechanisms, ways that the cancer cells outsmart therapy. And one of those common mechanisms, which is in green, the red circle of the little green circles, is called ESR1, and that is the estrogen receptor itself. So mutations in the estrogen receptor can cause resistance to aromatase inhibitors, and these mutations are acquired for patients who are on aromatase inhibitors. I think about this almost like a lock, but with a little part of that lock just taken away, such that it would open the door anyway. And this is important because you could imagine that even if you decrease the number of keys, that lock is still going to be open. So the only way to inhibit that lock would be something like degrading the lock, or having a molecule come in and maybe mucking up that lock, okay? Going back to that metaphor. And that is illustrated by some of these data. These are retrospective data looking at patients with ESR1, so estrogen receptor mutated ER-positive breast cancer, and those patients actually respond better to fulvestrant, the degrader of the estrogen receptor, than an aromatase inhibitor. These are retrospective studies. These do need to be prospectively validated, but many of us in the field really believe this to be true. So let me now talk about some drugs that are in ongoing clinical trials in this disease. So epigenetics is a very important scientific concept that the DNA, the DNA in all of your cells in your body is different, of course, but your hair is different from your eyes, is different from your skin. And so how does that happen? And so there are many ways of regulating the DNA through all sorts of markers and appendages. And this is the field of epigenetics. And you can see here you have chromosomes, and if you go sort of deeper and deeper into looking at it, they're wrapped around proteins called histones, and those histones can be modified in a lot of different ways. You can have molecules that sort of write over them, erase them, read them, or modify them in different ways. Now, one of these eraser-type proteins is called histone deacetylases. It turns out these drugs are actually approved in lymphoma and myeloma. And the way that I like to think about this is that when I was a kid, as a practical joke, we would take erasers in elementary school and put a piece of chalk in there so that if someone tried to erase the board, it would actually still write. So I reckon some people are nodding their head. But that's sort of how I think about these drugs, because they're inhibiting this eraser that erases part of the DNA or part of the molecules that are associated with DNA. The bottom line here is that when these types of drugs were combined with aromatase inhibitors, this was a phase 3 trial that reported from China at the European conference last year, that these drugs improve progression-free survival compared to exemestane alone. And then there's a phase 2 trial in the USA that reported both progression-free survival but also overall survival. And this is almost a 10-month improvement in overall survival by this new class of drugs that inhibits epigenetic pathways. And I think that this will be a really exciting area for the whole field to investigate these therapies further. And this drug, entinostat, is now in phase 3 trials. The second type of drug I want to talk about is called an antibody-drug conjugate, sacituzumab govitecan. This is a drug that is under active investigation in triple-negative breast cancer. And I think of these drugs like Trojan horses. They're antibodies that get attached to cells that contain a particular marker. And then when they get internalized, they release the soldiers. They release these chemotherapy drugs and kill the cancer cells. This was a clinical trial that reported a small phase 1 in ER-positive breast cancer. And this plot is called a waterfall plot. The idea is that every column is a patient's response to a tumor. So the more downward columns you have, the better. The more patients who had response to the drug, and more patients are having response to drug in this waterfall plot. And you can see the statistics here. But this is another really exciting therapy that I think will start to be investigated in ER-positive breast cancer. Another push in the field is, can we try to optimize SERDs? Can we make an oral version of fulvestrant? Many of you know that fulvestrant is a really sort of sticky, oily drug that's given in the buttock as an injection. And it does have poor bioavailability, meaning what percentage of that actually hits the cancer cell. And we know that, of course, if we could have an oral drug, a pill, it would go everywhere in the body. Excuse me. And so there are I've illustrated that here, but there are a large number of oral SERDs that are in clinical trials right now, which are listed on the side. And again, the idea here is that these would inhibit perhaps these ESR1 mutations that can drive resistance to therapy. Two types of targeted therapies that I wanted to talk about that are in trials right now. So we all know HER2 is commonly amplified in breast cancer, right? And there's another talk going on right now on that. But it turns out HER2, which is shown in the red circle, can also get mutated. And it turns out that these mutations are actually more common in ER-positive breast cancer than other types of breast cancer. And so there are drugs right now, neratinib is one of these drugs that's being investigated in patients with HER2 mutations. Here we're getting into this idea that perhaps sequencing of tumors may play a role in breast cancer and be part of the standard of care. Certainly in the PI3 kinase inhibitor space, we know that patients with mutations are the ones that respond to drugs, but these might be other examples. There's also a gene called FGFR1, which is highly amplified in about 8% of breast cancer, ER-positive breast cancers, and there are a number of drugs that are being investigated here. Finally, I did want to touch on immunotherapies. We're all, of course, thrilled that atezolizumab, which is anti-PD-L1, has accelerated approval now in combination with taxane chemotherapy in triple-negative breast cancer. Let me do the right column first. So these drugs are now being investigated in ER-positive breast cancer. The initial sort of studies in ER-positive breast cancer, unfortunately, the rates of response were really quite low. But just given the overall rationale for these therapies, there's a large ongoing trial right now called Morpheus that's testing atezolizumab plus multiple therapies in ER-positive metastatic breast cancer. And then on the left-hand side, I wanted to just point out a really interesting study that came out recently from Steve Rosenberg's group at the National Cancer Institute. This is this idea that you can educate your immune system, that you can remove T cells, which are immune cells, optimize them in a dish, reinfuse them into a patient, and kill cancer. And this is an example actually of an ER-positive metastatic breast cancer patient who underwent this procedure and actually had an amazing response in her cancer. And this is a really beautiful and provocative example of how modulating the immune system can increase survival in this disease. So that is all I have. I have 1 minute left, so I think I made the time. But I just want to reiterate that the future really is bright, and it's really, as an oncologist, I really view my role as trying to be very honest about communicating prognostic information, but also be very honest about the fact that the landscape of therapies is forever expanding, and that this is such a fast-moving field. And so I hope that that you all were able to learn something today, and thank you so much for your time, and thanks to LBBC for inviting me.
Thank you very much, Dr. Vasan. Really, really interesting stuff. I've been going to a lot of conferences. I go to San Antonio, I do all this stuff. But whenever I hear someone like you speak to an audience of people like us, it just makes me feel so good because you can translate some of the very technical things for us. But sometimes we have a lot of questions, and we do have a lot of questions
All right.
today.
Thank you for that.
So one of the issues around some of the new ER antagonists, or whatever you want to call them, and the clinical trials, is that the people with HER2-positive disease are not included. Why would that be? That, shouldn't it be that if you're ER-positive, whether you have HER2-positive or not, you should be included in the trials that are really targeted toward ER-positive therapies?
Yeah, that's a great question. So ER, we all know the receptor subtypes in breast cancer, ER, PR, HER2. And ER is, as I mentioned, what's called a transcription factor. It controls DNA the making of RNA from DNA. HER2 is a protein that's highly amplified in breast cancer, and we really call that what's called a driver oncogene, meaning that if you take cells and you amplify the HER2, it will cause breast cancer. Some of this gets into some sort of maybe academic and technical lingo, but estrogen receptor by itself we think of as a weaker driver than HER2, and just in the sense of as everyone in the room knows, HER2-positive breast cancer was very difficult to treat 10, 20 years ago when we had very few agents. And the natural history of that disease was faster, if you will, than ER-positive breast cancer, where women can live for decades with their disease. HER2-positive breast cancer, in the absence of therapy, women do not live for decades with that disease. And so there's one of the big issues in cancer research is looking at all these different drivers and thinking that some drivers might be more potent or powerful than another. And that becomes relevant for a patient with triple-positive disease, with ER-positive, PR-positive, HER2-positive disease. How do we manage those patients? So the first-line therapy would be really treat the HER2-positive disease and then start some sort of an endocrine therapy. But after that, it really is it's a black box. We don't have trials that look at this particular subgroup. So first off, to answer your question, what we need is more trials looking specifically at triple-positive patients. But second, and there are trials right now that are looking at, for instance, CDK4/6 inhibitors in the context of HER2-positive breast cancer. There's actually a really amazing study that came out in Nature looking at CDK4/6 with immunotherapy in HER2-positive breast cancers and maybe also ER-positive breast cancers. So I think that part of it is the design of clinical trials, that we need to start addressing these groups of patients that end up being large percentages of patients. But part of it is also that from a basic science point of view, we really think of HER2 as being more of a potent oncogene and more of a driver. But certainly anecdotally, what I've seen with patients who have triple-positive disease is that if they're on their 10th, 11th line of therapy, we start to feed in or sprinkle in some endocrine therapy on the side. And so, but I think that's such an important question. It really is an example where the science, I don't think, has caught up with the way that we treat patients.
Right, and it also speaks to patient involvement in designing clinical trials. Those of you who are near a research center, you may want to talk about, do they have patient advocates actually looking at clinical trial design? And if not, why not? I think we need to really stand up for that. What are the best options if you have HER2 positive, ER-positive, HER2-negative breast cancer, and it's endocrine therapy resistant? So I'm resistant to endocrine therapy. What do I do?
Yeah. So there are a lot of factors that we think about. You know, what is the definition of endocrine therapy resistance? In clinical trials, a lot of times we think about if you've been on therapy for maybe less than a year, or if you're on endocrine therapy and that next set of scans already shows progression, you never responded in the first place. So first of all, that definition of what endocrine therapy resistance is somewhat mutable. And again, I think what's challenging in this field is that we know that if a patient is resistant to an aromatase inhibitor, we could offer fulvestrant and a CDK4/6 inhibitor, and those are endocrine therapies. They're different endocrine therapies, but they resensitize to endocrine therapies, to ER. The cancer cell has bypassed that endocrine dependence, but then you go back into the sandbox with a different drug and something else, combination, and suddenly you're able to re-achieve the endocrine sensitivity. But of course, that's contrasted with sometimes patients, of course, will be on multiple hormone agents, maybe 3 or 4 different types, and progress through everything, and then we start thinking about chemo. Certainly, when I see a patient, I mean, I think about the bulk of disease. Is that disease causing changes in the organ function, like kidney numbers, liver numbers, just the sheer amount of disease, where the disease is located? Of course, patients who have bone-only disease and are maybe less symptomatic, those might be patients I think more about the endocrine therapies on versus chemotherapy. But these are really subtle conversations. These are conversations that are very important that really are a conversation between an oncologist and a patient to try to explore the therapies a patient's been on, their side effects, their other medical comorbidities, that sort of thing. And you know, again, we need more trials to sort of to investigate this.
Yeah, and a lot of the people are doing things off trial, of course, because as a clinician, you have to decide the best option for your patients. So in the clinic, have you seen any success of someone being on a CDK inhibitor and then going off on something else and then going back to that inhibitor?
That's a good question. So I mean, again, these are very, very, very small numbers. In general, unless it's on a clinical trial, in general, we don't offer at Memorial CDK4/6 again if a patient has received it previously in the metastatic setting, unless it's on a clinical trial. We actually don't have data clinical data, to my understanding. These are all in clinical trials, but we don't have any sort of standard of care data that re-exposure to a CDK4/6 in the future after having received it initially is effective. But there are oncologists that do that for a variety of reasons, and I think it's again this is just an issue in the field we need to come to a consensus on. But one thing I will say is that one thing that's interesting about the CDK4/6 inhibitors I didn't mention, abemaciclib, which is actually approved as monotherapy as well. And so although that trial didn't test that drug as monotherapy in patients who received palbo first or ribo first. And so could those patients, could that be an option for patients who initially received CDK4/6 and then many years later have a recurrence, perhaps? But I think that we have to understand, again, the science behind who responds in the first place to CDK4/6, I think, before we necessarily start reintroducing that drug in the absence of better data.
Right, and one of the issues is because those numbers of patients become so smaller and smaller population, it's difficult to run a clinical trial when you're asking for people to enroll who have already had this drug and they've progressed on it. And so that's one of the challenges of people who design clinical trials and work on
and there
them.
are a number of clinical trials that address this very question that you're bringing up, Sandy, that of palbo after palbo, palbo post palbo, and there are a lot of trials that are looking at this.
Mm-hmm. So in de novo metastatic breast cancer, sometimes doctors are saying, well, you already have cancer, so what's the point of removing the breast cancer tumor, the primary tumor? What is going on with breast surgery and ER-positive de novo metastatic breast cancer?
That's a great question. So this is the question of surgically removing the breasts in a patient with metastatic disease, and are there changes in survival? So there were actually 2 large clinical trials that looked at this. My understanding is this was, I think, all subtypes. It wasn't just ER positive. One of those trials came from India, and one of them trials, I believe, came from the Middle East. don't quote me on that, but sorry. But the trials actually disagreed with each other. One was positive, one was negative. And I think in the field, we think that most likely it does not confer a survival benefit. There may be other reasons that a patient, wants mastectomy or surgery that are different. I will say that there is some preclinical data that, and Larry Norton, one of the godfathers of the field, who's one of my mentors, of course, at Memorial, has worked a lot on this. This idea that the breast cancer in the breast, there's some sort of an equilibrium with the breast cancer in the metastases, and maybe disrupting that equilibrium by performing surgery may even potentiate the breast cancer. There's not necessarily, and there is a trial that's actually reported perhaps increased growth or increased attenuation of effects from that. So I think it's just a big open question. Could there be differences between ER versus HER2 versus triple negative? Maybe. Yeah, maybe.
All right. For in premenopausal patients who have had a oophorectomy and they're resistant to hormonal therapy and CDK, is chemo their only option at this point?
So no, it's not their only option. I mean, certainly clinical trials are an option. I would say clinical trials and chemotherapy. Again, I think this gets at the point, though, of what does endocrine resistant mean? There are definitely patients, for instance, who have a large amount of disease, and maybe they get a chemotherapy that really has a dramatic effect and shrinks the tumor, and the patient's feeling great. We may go back to an endocrine therapy that we hadn't explored initially, even though the patient had progressed very quickly on prior therapies. And again, this speaks to the natural history of the disease. If a patient, just because a patient has received a therapy in the past, it doesn't mean they can't receive it in the future. But for instance, if someone who has metastatic disease for 20 years, we may end up revisiting some of those older therapies, thinking if the cancer forgot about that therapy or didn't have changes reminiscent of that therapy. And so it doesn't exclude non-chemo options. And I think, again, as an oncologist, my goal is also, we all want the most number of options. We want to leave as many options on the table as possible so that we can make the most educated decision.
So one of the issues about taking combination therapy and progressing is that we don't know which or both of the drugs are actually causing the progression. So how do you differentiate of what you should stop and what you should start at that time?
That is, again, I think that's such an important question. If a patient gets Palbo AI initially and then progresses, often it will just be fulvestrant monotherapy. But who's not to say that fulvestrant with Palbo is better or worse or the same compared to fulvestrant alone? Again, I think that these are the questions that we really need clinical trials to answer, and there are clinical trials ongoing to address this. I think that, and this is the challenge with combination therapies really in all of cancer. What's interesting, though, this is my opinion, is that, and I think this is substantiated by the everolimus data that I showed you, as well as in some ways the CDK4/6, is that all the endocrine agents get improved with everolimus. And in the PI3 kinase inhibitor space as well, there are many early stage clinical trials that show that regardless of AI or fulvestrant, adding a PI3 kinase inhibitor will improve that therapy. And so that, I think, speaks to this sort of idea that maybe these endocrine therapies we can really think of as just one class, and that we can toggle back and forth between with adding these second therapies, these targeted therapies to the endocrine agents, and find creative ways of doing that. But again, I think that this needs to be done on clinical trials.
Is fulvestrant or Faslodex same thing? Sometimes I know you talk about the regular name, but we usually use the trade name. But for Faslodex, is that considered something that is a first-line treatment for most with ER positive, either de novo or not metastatic breast cancer?
Yeah, I think there might be some practice variation across the country for this. There are oncologists who will give that in the first line, sometimes even with Palbo in the first line for de novo patients, et cetera. But and the Falcon, they're extrapolating from that Falcon data, the data of fulvestrant versus anastrozole, which had a 3-month improvement in PFS. But personally, I don't in general. There may be reasons, again, if a patient starts an AI and maybe they're having horrendous joint pains, maybe we'll think about fulvestrant, even if it's been a small amount of time. But it is an option, and I think that, this is an example where, again, because this field is so fast-moving, what happens is clinical trials get designed at one point in time, and they take many years to report. And then by that time, if a drug like CDK4/6 comes along and totally changes everything, then this older trial reports, and then suddenly, even if it's positive, you're left with, well, how do we interpret this given this recent blockbuster? And I think this speaks to how quickly the field is moving, that we're even having these questions in the first place. We're lucky in the field of breast cancer to be having these questions because there are many cancers that we actually don't have those questions for. Yeah.
And a lot of studies we read are about, we read them and they sound so great, and then we find out that it was done in mice. And that it doesn't necessarily translate over into humans, particularly with estrogen type drugs. Is that true?
Excuse me. It is. We actually don't have a lot of great mouse models for estrogen receptor-positive breast cancer. You all probably have heard of genetically engineered mouse models, that sort of thing. We actually don't have any for ER-positive breast cancer. And what we do in the lab to study that is we take what's called xenografts, which is patient tumors that patients have graciously donated their tumor. We isolate cells from that tumor and we inject them into mice, and then we do experiments to try to get a better understanding of the cancer that way. But this is a big problem in the field, is we don't have great mouse models for ER-positive breast cancer, whereas there are some other cancer, lung cancer, pancreatic cancer, we actually have really good mouse models. So again, this is another push that I hope you all, you're all crusaders in your community, you're all advocates, and we need to advocate for better science and better ways to model these diseases.
Right, and we also don't have very good models for bone mets in mice. We do for lung, but not bone.
That's right.
And so that makes it more difficult. We talk about ER and PR, but what about androgen? Can you talk a little bit about the role of androgen in this?
So this is a great question. So there are other hormone receptors, and the androgen receptor, which is very important in prostate cancer, turns out also to be expressed in a large number of triple-negative breast cancers. And there's been a lot of work. Tiffany Traina at our institution has done a lot of work looking at what are prostate cancer drugs, Casodex, which is bicalutamide, Xtandi, enzalutamide, in breast cancer, in triple-negative breast cancer. But it turns out there are also a lot of ER-positive breast cancers that also express the androgen receptor as well, ER-positive, AR-positive. Miles Brown at the Dana-Farber, who's a really preeminent cancer biologist, has done a lot of work in this area. I think it still remains to be seen. My personal sense is that AR I think of as a weaker driver than ER, but and perhaps that's substantiated by clinical trials. There's really no large phase 3 trial that has shown a benefit for these androgen receptor inhibitors in triple-negative breast cancer or in estrogen receptor-positive breast cancer. But this idea that you have, so the estrogen receptor is in the nucleus of the cell, the sort of the soul of the cell, the center of the cell, and the androgen receptor is also there. And there's actually a lot of early scientific data that these two receptors can sort of crosstalk with each other and tickle each other and maybe stimulate each other. And there's and so the idea that you can inhibit the androgen receptor in something like ER-positive breast cancer and get effect, I think it's a very rational hypothesis, and I think that we need more data.
Can you explain I can't even pronounce it, alpelisib trial? Yes, thank you very much. And who qualifies for that trial? And do you know what the side effects are of that particular drug?
Yeah, so these trials are looking at patients who've progressed on aromatase inhibitor therapy. And this trial tested fulvestrant with and without alpelisib. There are now 5 clinical trials that have looked at PI3 kinase inhibitors that are phase 3 trials, 5 trials now, that are positive trials. And this space is important when we talk about side effects because it gets to the difference between what is something that's just merely statistically significant versus something that is clinically meaningful. And all of these trials are actually statistically significant. The patients who got the PI3 kinase inhibitor had a longer progression-free survival than those who didn't. But in many of these trials, the side effects are actually quite tremendous. In the case of alpelisib, hyperglycemia and rash are some of the most common symptoms. Hyperglycemia can be managed with different diabetes agents, many times oral drugs like metformin or other newer oral anti-diabetes drugs. Sometimes patients do need insulin. Rash can also be well managed. Those are really the main side effects. There are other, if you guys read about PI3 kinase inhibitors, a lot of the different drugs have sort of different side effect spectrums, but for alpelisib, those are the main side effects we see.
For ER-positive Mets, have you seen anything that shows that liquid biopsy is a good predictor of progression and characteristic of the metastatic tumor?
Yeah, what a great question. So this is the holy grail in the field, right? If we had some sort of a blood biomarker that is better than a tumor marker that predicts how patients are doing on metastatic therapies or for screening, et cetera. So there are trials that have looked at this. There is actually from our institution, there was a clinical trial looking at an AKT inhibitor. This is another part of the PI3 kinase pathway, and looking at circulating tumor DNA, that is pieces of the DNA from the tumor that are detectable in the blood, and trying to sort of use that to monitor response to disease. There's also a very classic study in the New England Journal from a couple years ago that also looked at this. And you know, I'm not a ctDNA expert. My take on this field in breast cancer is that there are a lot of really beautiful examples where the amount of DNA in the tumor really tracks with overall systemic disease, and that response to a tumor correlates with a decrease. But we haven't really seen these, unfortunately, in large numbers. That being said, I do think that there's a huge area of research. I do want to say that in the field of lung cancer, in patients getting Tarceva, which is the EGFR mutant lung cancer therapy, that there's a common resistance mechanism. There's an FDA-approved test now that's very standard for patients who get resistance to look for that resistance mutation. So that's an example where they're looking for a specific mutation rather than necessarily targeting, or rather than necessarily tracking the amount of disease and the regression of disease. I think that things like ESR1, some of that work I showed you on the correlation was based on circulating tumor DNA. So that's another good example where they're detecting it in the blood. They don't need to biopsy a tumor because they're looking for a specific mutation. So there are a lot of applications for circulating tumor DNA, and I'm really hopeful that you know, in a couple years that all of you will be able to take a blood test rather than, you know, and that may give you more of a sense of what's going on than a scan. And I'm really, really hopeful. I mean, I tell my patients all the time that I'm very hopeful that we'll have such a test.
Right, and a scan doesn't have to show like a million, it has to be 1 million cells before it even shows up on a scan, where in blood, it could be a single cell.
That's right. And I think especially for bone disease, for ER-positive breast cancer, you know, we don't have great ways of imaging the bone. I think you all know that. And if somehow there could be a surrogate in the blood that might pick up on that, that would be amazing. That would be a huge advance.
Yeah, that's great. There's a few questions about removing ovaries. One for premenopausal. How do you know when, after your ovaries have been removed, that you're actually in menopause and that AIs will be more effective? And for postmenopausal, does removing ovaries help in getting rid of the residual estrogen that comes out of ovaries, even when they're kind of like going by the wayside, particularly for someone who has a history of familial ovarian cancer? Okay,
great question. So the first piece of the so the first part was in premenopausal women who are getting their ovaries removed. How do you sort of monitor that or think about that? So we really think about that clinically. If a patient hasn't had a period within a year, we call that postmenopausal. That's assuming that they're not on endocrine therapy or chemotherapy. That question comes up more often in the localized disease setting than in the metastatic setting. In the metastatic setting, if a patient is, if we're concerned, if we don't know, let's say a woman has had hot flashes and then maybe it's been 11 months but not 12 months, and we really want to confirm that. Sometimes what we'll do is we'll stop hormone therapy for some amount of time and check hormone levels, FSH, LH, and estradiol. These are not perfect tests by any means. They're influenced by a lot of factors, but high FSH is suggestive of menopause. High FSH and low estrogen, of course, is suggestive of menopause. So these are some tests that sometimes we think about. Again, actually, most of the time we think about that again in the localized setting rather than in the metastatic setting. we do know that these are equivalent, ovarian suppression with an injection is equivalent to surgery. However, in a patient who has familial ovarian cancer, where we're very concerned about a BRCA mutation or a mutation in another cancer predisposing gene, oophorectomy, removing the ovaries, has a survival benefit. And please never forget that. This is a huge advance in the field where what we call prophylactically removing the ovaries before something happens. That act, that surgery in and of itself, improves survival for women with BRCA mutations. And so I think for those patients, it's a different question of why they're, of course, removing the ovaries will decrease the effective amount of estrogen. But for those women, the concern is that we want to prevent them from getting ovarian cancer. There was one other piece is that, a lot of people, there's been a lot of literature looking at measuring estrogen levels, if that correlates with response both in the localized and the metastatic setting. Unfortunately, really no study has really panned out on that. It is counterintuitive, right? You would think you could just measure these hormones, but measuring the hormones in and of themselves is actually technically, from my understanding, very difficult. And there's things like circadian rhythms where the amount of hormones at 5 a.m. could be totally different from 5 p.m. and things like that. There are a lot of factors that alter that. And so, we really go based on clinical symptoms.
Before we take our lunch break, I have a big question that everybody wants to know is, what's your opinion about taking treatment breaks? Like we've got a family reunion coming, or we want a graduation, we're on something that's causing diarrhea. Is it okay for us to take a break? Will it impact our survival? Is it going to be a big deal? Or can we just kind of take it off for a while and then pick up again?
Ooh, great question. So I think that part of this is addressed by the natural history of the disease. I think if a patient has just started on therapy, just started on, let's say, first-line therapy, Palbo AI, the idea of stopping therapy for a month is not something I would recommend. But if a patient has been on therapy for many, many years, and if they need sometimes what we call treatment holidays, or if the amount of disease, metastatic disease they have is just incredibly small. I have a patient who has one very, very small bone metastasis, but she's been living with metastatic ER-positive breast cancer for many years. That is a patient that there might be a reason or a rationale to consider a treatment holiday. Sometimes when we think about treatment holidays, it's really in the consideration of in the setting of chemotherapy, because chemotherapy has many cumulative side effects like decreasing blood counts and decreasing your white blood cell counts and things that could creep up or could add to problems in the future. So I think, again, it's very much a case-by-case basis, but in something like ER-positive breast cancer, where this natural history is tremendous, can be tremendously long, these are great options for patients if they're having a lot of side effects or but that being said, obviously, if you're going on a vacation, take that vacation. Go live your life. And there are a lot of creative ways to manage side effects, even if you're on therapies outside of the country, or traveling outside of the country, or that sort of thing. Your doctor's a phone call away. And the good news is that in a lot of other countries, these are now standard. CDK4/6 inhibitors are standard of care, and so the world is speaking to each other. And many of these trials are actually worldwide trials, which is also amazing.
That's great. The biggest question everyone has is, are you taking new patients?
Oh, thank you. I am taking new patients. I live and work in New York City. But I think this is the thing is that, I'm from West Virginia. Listen, I get it. Like, everyone lives in different places. And what's amazing about the oncology community is that everyone gets to share knowledge and disseminate knowledge everywhere. And it's really important that patients get treated, I think, close to home, unless there's some blockbuster clinical trial maybe. But again, you can't lift up your whole family and go somewhere to travel for something that's very hypothetical. And I think these are all important questions. But my dad is a radiation oncologist in West Virginia still, and and he's amazing and at what he does, and he knows everything about medical oncology. So it's just there's great people everywhere, but I am taking new patients.
Do you do virtual second opinions, or do you always have to go in person?
So Memorial actually has started doing virtual second opinions, where as long as all the pathology gets. Anytime you get a second opinion, what's great is that you see a medical oncologist, but you also get a pathology review, you get a radiology review. Sometimes there's differences in the reads and things like that. We do offer that. I know a lot of other centers are starting to offer that as well. I think that Obviously it's an option. It costs money, and that's not trivial. And I think the patient that I would encourage to pursue this would be someone who maybe has something unusual about their disease, somewhat of an outlier, or something unusual on a sequencing report, or just something unusual that maybe if their doctor hasn't seen before. I think those are the types of patients where it makes sense, but it's very much an individual question.
Okay, great. Thank you so much, Dr. Vasan.
You're welcome.
All right. Our live streaming will begin again at 2 o'clock, and it'll be on Bone Meds.